If you're a clinician who manages liver disease, you know the ground is constantly shifting. Well, the 2019 AASLD Guidance on alcohol-associated liver disease drops some really critical updates that we all need to be on top of. So we're going to break down the 5 most practice-changing takeaways in the next 5 minutes, starting with just how big this problem really is. And here's why this is so urgent right now. Between 2008 and 2016, the death rate from alcohol-associated cirrhosis just skyrocketed. But what's really terrifying is that the sharpest jump, over 50%, was in young adults, people between 25 and 34 years old. This isn't some distant problem. It's a crisis that's walking into our clinics and hospitals every single day. Okay, so right from the top, the guidance pushes for a big change in how we talk. We're moving away from alcoholic liver disease and toward alcohol-associated liver disease. Now look, this isn't just about semantics. It's a very deliberate clinical tool. It helps reduce the stigma our patients and their families feel, and that helps us build a much better therapeutic relationship right from day one. So here's our roadmap. We'll follow the path you would with a patient. First, we'll get a handle on the scale of the epidemic. Then we'll dive into how to screen and diagnose these patients earlier. From there, we'll tackle the acute crisis, managing severe alcoholic hepatitis. Then zoom out to treating the underlying disorder, and finally, we'll cover the really new landscape of liver transplantation. All right, so first things first, let's really frame this problem by looking at its true scope. You know, the numbers here are pretty stark. ALD makes up a huge chunk of the cirrhosis burden across the globe. And here in the US, roughly 2% of the entire population is living with some form of it. This has caused a major flip in hepatology. ALD has now blown past hepatitis C to become a leading reason for liver transplants. And of course, that comes with massive medical costs, mostly from people being admitted to the hospital again and again. So if the problem is that big, the next logical step is, how do we find these patients sooner? And that brings us right to our second section, screening and diagnosis. So, the million-dollar question for all of us is this. How do we systematically find patients who are drinking at risky levels before they show up with end-stage liver disease? Well, the good news is that guidance gives us a really clear, evidence-based way to do it. And it's called the SBIRT process. That's screening, brief intervention, and referral to treatment. It kicks off with one super simple question, the one recommended by the NIAA, about binge drinking days. If the answer is even one time, you then move on to a validated tool, like the Audit C. It's this tiered approach that makes it so efficient and effective for flagging who needs a quick intervention or a formal referral. But of course, sometimes you need some objective data to go with that. When you need to confirm recent drinking, biomarkers are key, but the guidance really helps clarify which ones are best. See, CDT can give you a false positive if liver disease is really bad. And urinary ETG is okay, but it has a super short detection window, like 3 days. The guidance really points us toward PF as the better marker. It's highly sensitive, gives you a 2 to 3 week window, and, this is crucial, its levels aren't thrown off by how severe the liver disease is. And to really hammer this point home, here it is, straight from the guidance. Universal screening? It's not optional anymore. It's the standard of care, whether it's in primary care, a GI clinic, the ER, or on the inpatient wards. We should be screening everyone. Okay, let's shift gears to one of the most high-stakes situations we deal with, managing severe alcoholic hepatitis, or AAH. So first, a quick refresher. Alcoholic hepatitis is a clinical syndrome. It's that rapid, frankly, terrifying nosedive in liver function in a patient with a long history of heavy drinking. And while there's a specific picture on biopsy, we almost always have to make the call clinically. With AH, prognosis literally dictates treatment. We have to use scores to figure out who's at highest risk. The 2 big ones at admission are the Maddrey's discriminant function, the MDF, and the MELD score. An MDF of 32 or more, or a MELD over 20, that's your signal for severe AH. It's the trigger to think about steroids. Then, on day 7, the LIL score tells you if your treatment is even working. If that score is over 0.45, they're not responding, and you have to stop the steroids. So this puts it all together into a pathway you can actually use. Step 1, you assess severity with the MDF. Step 2, you check for contraindications, and the big one is an active, uncontrolled infection. If the coast is clear, you start prednisolone, 40 milligrams a day. The guidance also says to consider adding IV Nacidil, which might cut down on early mortality and infection. Then, that LIL score on day 7 is your critical decision point to either keep going or pull the plug on therapy. And here's the official word. For patients with that MDF of 32 or higher and no contraindications, prednisolone should be considered to improve 28-day mortality. Now look, it's a modest benefit for sure, but it is still the best evidence-based tool we've got in this acute firestorm. But just putting out the acute fire is only half the battle. If we really want to change a patient's outcome for good, we have to treat the root cause. And that's what Section 4 is all about, treating the underlying alcohol use disorder. And I really want to be crystal clear on this point. Corticosteroids might save a life in the next month, but abstinence is the only thing that changes the long-term story. It is the absolute, undisputed cornerstone of managing this disease. We all know achieving abstinence is incredibly hard, so we should be using every tool in the toolbox, and that includes medications. The guidelines helps us pick the safest options for patients with a sick liver. Naltrexone is processed by the liver and carries a risk of hepatotoxicity, but acaprosate is cleared by the kidneys, and baclofen has actually shown benefit in a trial of patients with cirrhosis. That makes them much safer and frankly the preferred choice for this population. And the guidance backs this up directly. It says that even with limited data, using a camprosate or baclofen can be considered. It's a critical part of a true multidisciplinary approach to helping our patients. All right, let's get to our final section, the role of liver transplantation. And let me tell you, this area is going through a seismic shift. For decades, pretty much every transplant program had this rigid 6-month abstinence rule. The idea was that it gave the liver time to maybe heal on its own, and it acted as a kind of test of sobriety. But the evidence has really evolved. We now know that this fixed rule is actually a pretty poor predictor of who's going to relapse after transplant. And what it does do is penalize a lot of patients who are actually good candidates, but just won't survive the wait. And all of this has paved the way for something that's a real game changer: early liver transplant for very select patients with severe AH who fail medical therapy. The key here is careful selection. We're usually talking about patients having their first major liver decompensation, who go through an intense psychosocial evaluation to make sure they've got great social support and a low risk of relapse. And the results are just incredible. 3-year survival is around 84%, with less than 20% of patients having sustained alcohol use after the transplant. So in the end, the new guidance officially tells us to move away from this dogmatic, one-size-fits-all 6-month rule. Selection has to be more holistic, based on a deep dive into the individual patient, not just on a calendar. And that leaves all of us with a really critical question for the future. As this practice of early transplantation grows, our next huge challenge is going to be developing standardized, fair, and consistent rules for picking the right patients. How do we make sure that every patient gets a fair shot, no matter which hospital they walk into? That's a challenge we're all going to have to tackle together. Thanks for joining me.